So Bismillahirrahmanirrahim. Now we are going to continue with the 11th session of the Repro unit. So there was a point about aneuploidy that was to be discussed previously. So aneuploidy is defined as a chromosome number that deviates from the multiple of the haploid set, and it is associated with abnormalities in the cell function, such as in the cancer and in the organismal development, such as Down syndrome or maybe the mosaic variegated aneuploidy, blah blah blah. So this is aneuploidy that the cell genome deviates from the multiple of haploid set. Like it can be 2x. Normally we have, like when we say 2n, single n is haploid set and 2n is basically the diploid set. If the number deviates from the multiple of that, so it means that the person is having aneuploidy. So let's continue with the session over here. So we have to talk about hydatidiform mole. What is hydatidiform mole? So hydatidiform mole or hydatid means fluid filled cyst, and the mola in Greek is for the false pregnancy. Cystic swelling of the chorionic villi will be there. Villi forms clusters. Cluster is basically cluster of grapes, and ultrasound shows no storm appearance. Proliferation of the chorionic epithelium, only the trophoblasts will be there. We basically discussed that in last section, but I am continuing that from over there. So snowstorm appearance on ultrasound, proliferation of the chorionic epithelium, only the trophoblast will be there. It is associated with the HCG mediated sequelae, early preeclampsia before 20 weeks, theca lutein cyst, hyperemesis gravidarum, and hyperthyroidism will be there. It presents with vaginal bleeding due to the separation of the molar villi from the residua, uterine enlargement more than expected, and pelvic pressure or pain can be seen. Treatment is basically done with the. So for the treatment, what do we do? For the treatment, we do use a dilation curettage and methotrexate and monitor the beta HCG level. Then we have complete mole and partial mole. So there are two types of hydatidiform mole. One is the complete mole and then another one is a partial mole. So talking about the complete mole, fertilization of the empty egg. Okay, all chromosome of the paternal origin and no maternal chromosome will be there. Like it is like there we have an ovum and due to some reason it is anucleated or it does not have the chromosome. It has nothing inside. It is an empty egg, and then the sperm comes over here and it fertilizes this particular empty egg. Okay, that is a very weird kind of a sperm. So like that, so it enters the ovum, it fertilizes that, and then the genetic material of the father that is coming from the sperm that duplicates itself. So that is going to give us no maternal chromosome, usually 46XX karyotype. Due to the duplication of the haploid sperm, 23X will lead to 43XX. 46YY does not occur, it is lethal, it is not viable with life. So 46Y, we need at least one X chromosome for the fetus to be viable. So if there is no X chromosome, for example in the case of 46YY, that is not viable, that is a lethal condition. Rarely 46XY moles occur, empty egg fertilized by two sperms. So how does that happen? Suppose that this is one ovum and that is supplied, that is fertilized by two sperms simultaneously, or you can see that in this picture. So the first condition we saw that there was duplication of this particular thing, the genome of this sperm was duplicated, or there may be another condition which two sperms simultaneously fertilize this empty egg and there will be the genomic material of both of these sperms together inside the cell, and that can give us the picture of the 46XY, maybe 46XY, like this sperm may be containing X and this may be containing Y. So 46XY picture is possible only if an empty egg is fertilized by two sperms. P57 negative on immunostaining. P57 is basically a cyclin dependent kinase only expressed in the maternal chromosome. Okay, due to the fact of imprinting is a phenomenon. Let me see that what is imprinting. So imprinting, yep. So imprinting means humans inherit two alleles from the mother and father. Both are functional for the majority of the genes, but sometimes one is turned off or stamped and does not show in the offsprings. That gene is imprinted. Imprinting means that the gene is silenced and gene is from one parent is expressed. So if you're saying that P57 is coming only from the maternal chromosome, which means that the paternal chromosome for that particular allele are imprinted. So P57 will be absent in these, when we will do the genotyping of such cells, so there will be absence of the P57, that will not be present. P57 negative results will come out. No fetal tissue because maternal chromosomes needed for the fetal tissue. There are no maternal chromosomes, so that is why there will be no fetal tissue. No fetus to drain villi. Massively swollen villi will be there because we have to drain the villi. So that is, I guess, a mnemonic or something. So why are villi so enormous? Because there is no fetus to drain them. That is why they're so enormous. Most common form of the mole pregnancy is the 46XX or 46XY chromosome rarely, but this form that is called the complete mole, in which there is no fetal tissue. Only a hydatidiform mole is filling the uterus. Uterus is bigger than the expected size of the pregnancy, and the genotype is the genotype contains only the paternal chromosomes. There is no involvement of the mother. In case of partial mole, it is less common form. Fertilization of the normal egg by two sperms. Some fetal tissue like maternal chromosomes are present, so there will be some fetal tissue. Some villi, it's a mnemonic again. Some villi drainage, and that there will be less swollen villi. Usually triploid like 69XXX, 69XXY, or rarely 69XYY, but they can never be 69YYY because we need at least one X chromosome for the survival. The fetus is not surviving anyway, but that is not possible. Like this combination is not possible at all because we need at least one X for the viability of the combination. So otherwise it is not possible even. P57 will be positive because maternal genetic material is present, and P57 is expressed by the mothers. So remember these things about that the although the uterus size will still is still larger than the expected size, but it is smaller in comparison to the complete mole. Then here we have the picture of that. So molar pregnancy, suppose ovum with inactive maternal chromosome, either there is no nucleus or there is inactivation of the maternal chromosome. What happens? The sperm will enter the ovum and then it will duplicate itself, duplication of the paternal chromosome, and there will be 46XX, that is the complete mole. In the case of a complete mole, but the pathogenesis or the mechanism is different in the case of this one. When two sperms are fertilizing an empty ovum with an inactive maternal chromosome, so resultant will have 46XX or maybe 46XY. And the fertilization by two sperms is happening for a normal ovum, resultantly we will have a triploid picture in which there will be 69XXX, XXY, or XYY. So this picture can also be there. Then we have hydatidiform mole. So this is the table from Uworld. So hydatidiform mole, the clinical features include the difference of the complete and partial mole. So we will first do the complete ones and then we will shift our focus to the partial ones. Clinical features for the complete are that there will be vaginal bleeding, enlarged uterus inconsistent with the dates, extremely high beta hCG level, that is very important. There will be extremely high beta hCG level that can cause hyperemesis gravidarum, preeclampsia, hyperthyroidism, because alpha sapinode, the TSH and beta hCG are the same, and theca latent cyst can also be there because hCG is responsible for the persistence of the corpus luteum. Pathologic features, we don't need to do that. Pathologic features: diffuse trophoblastic proliferation and adventitious chorionic villi, bunch of the grapes appearance. Okay, so no fetal or embryonic tissue is present at all. Karyotype can either be 46XX or 46XY, and that is all paternal DNA only. Then immunohistochemistry will show P57 negativity because P57 was supposed to be coming from the maternal chromosome, which is absent in the case of a complete mole. Risk of the gestational trophoblastic neoplasia, that is 15 to 30%. Moving on to the partial mole. So clinical features include vaginal bleeding, okay, crampy abdominal pain, okay, then normal uterine size. So uterine size is normal, it is not even enlarged. I'm sorry if I said that before. So the uterine size will be normal, and normal to high beta hCG levels can be seen. Pathologic features: some enlarged villi with the focal trophoblastic proliferation, okay, there will be some enlarged villi with the focal trophoblastic proliferation, and fetal or embryonic tissue will be present because for the development of the fetal or embryonic tissue we need the maternal chromosomes, which are present in the case of a partial mole. Karyotype can be 69XXX or XXY or maybe XYY. Maternal and paternal DNA both are present. Immunochemistry is P57 positive because of the maternal chromosome presence, and risk of the gestational trophoblastic neoplasm is less than 5%. So this is the table from the Uworld, from the first aid. So for the complete mole, okay, so let's do them one by one. So for the complete mole, the karyotype is 46XX or 46XY. Components: most commonly enucleated egg plus a single sperm, and that single sperm will subsequently duplicate into the paternal DNA, or maybe there is an enucleated egg and it is fertilized by the two sperms simultaneously. So that are the component of that. Then fetal parts will not be present. Uterine size will increase, beta hCG will increase dramatically. Imaging will show honeycombed uterus or cluster of grapes, and snowstorm on the cluster on ultrasound can be seen. So I guess these are the pictures. Like I guess this is the honeycomb picture, and cluster of grapes Okay, so this is the cluster of grapes. If you can find some grapes over there, let me know. And then in the B, they are showing snowstorm appearance in the ultrasound. So this is not, the honeycomb appearance. This is the snowstorm appearance. This is snowstorm appearance. Then we have risk of malignancy, gestational trophoblastic neoplasia, that is 15 to 20% risk, and risk of choriocarcinoma is about 2%. In the case of partial mole, the karyotype is 69XXX, 69XXY, or 69XYY. Component is two sperms which are fusing with one normal egg. Fetal parts will be there because partial fetal parts, and that is because the maternal chromosomes are present. Uterine size will be normal. HCG is increased, but not so much increased. Like HCG is normally increased during the pregnancy, early on during the pregnancy. Then imaging is fetal parts will be present. Risk of malignancy and gestational trophoblastic neoplasia is less than 5%, and risk of choriocarcinoma is rare. Then here you can see, I guess these are the moles or something, and here is also a picture of I don't know what, but there is also a picture. Moving forward, we have choriocarcinoma. Malignancy of the trophoblastic tissues is called as a choriocarcinoma, as you can see in this picture A. So this is the malignancy of the trophoblastic tissue. Cytotrophoblast, syncytial trophoblast. No chorionic villi will be present. Choriocarcinoma may arise as a complication of the gestation, spontaneous abortion, normal pregnancy, or hydatidiform mole. They all may lead to the choriocarcinoma formation, or as a spontaneous germ cell tumor as well. Choriocarcinomas that arise from the gestational pathway respond well to the chemotherapy. Those that arise from the germ cell pathway, they do not. So the spontaneous one, or those arising from the germ cell pathway, they do not respond to the chemotherapy very well. But the choriocarcinomas which are arising from the gestational pathway, that is after a spontaneous abortion and maybe a normal pregnancy or hydatidiform mole, and these conditions, if they develop a choriocarcinoma by the gestational pathway, they respond very well to the chemotherapy. Presents with developed during or after the pregnancy in the mother or baby. So the choriocarcinoma developed during or after the pregnancy in the mother or baby. Abnormal vaginal bleeding and uterine enlargement will be seen. Significantly increased beta HCG levels. Increased frequency of the bilateral multiple theca lutein cysts. Shortness of breath and hemoptysis. Early hematology spread to the lungs, and cannonball metastasis can also be seen. So here you can see, I guess this one, and okay, this is a very beautiful picture here. So these are the cannonball metastases which can be seen in the case of a choriocarcinoma. Remember that, because it is a very important finding, and such buzzwords like a cannonball metastasis or other findings like that, they are very, very characteristic, and they often test you by giving these buzzwords, or maybe they can also give the x-ray, but they often give the buzzword in the step 1 question stem. Then pathology, gross picture, bulky intrauterine mass that is usually soft and yellow white. Extensive area of necrosis and hemorrhage can also be seen. On microscopic examination, abnormal proliferation of the mononuclear cytotrophoblast as depicted by the red arrows. Where are the red arrows? There are no red arrows. There are no red arrows. So microscopic picture will show abnormal proliferation of the mononuclear cytotrophoblast and multinuclear syncytial trophoblast, which are given by the green arrows. They are given in the picture with the first year 2022 maybe, but there is no picture for that. So remember that there will be abnormal proliferation of the mononuclear cytotrophoblast and multinuclear syncytial trophoblast, because we know that the cytotrophoblast, if suppose this is a zygote, no, this is not a zygote, this is a blastocyst. So in the blastocyst, the outer layer becomes cytotrophoblast and the multinuclear external layer becomes syncytial trophoblast. No chorionic villi are present versus the molar pregnancy where the chorionic villi are present and they are also admixtures. So in the case of a choriocarcinoma, the chorionic villi will not be present. You must differentiate that choriocarcinoma from the molar pregnancy. Moving forward, we have histology of the gestational trophoblastic disease. So here we have it. Like for the partial mole, the classification, it is kind of benign condition. Trophoblast focally hyperplastic villi, they will be focally enlarged and hydropic. Hydropic means admixtures, and fetal embryonic tissue is present, and there will be a triploid configuration, that is 69 chromosome in different configuration of the sex chromosome like XXX, XXY or XYY. Complete mole, it is also a benign condition. Trophoblastic, benign not in the sense that it is not dangerous, benign in the sense that it is not malignant or it is not metastatic. So it does not have a metastatic potential, that is why it is considered benign, or it is called benign over here. Trophoblast, they will be diffusely hyperplastic, villi will be diffusely enlarged and hydropic, and fetal and embryonic tissue will be absent. Invasive mole, that is malignant because invasive mole can spread. Trophoblast, diffusely hyperplastic with myometrial invasion, villi diffusely enlarged and hydropic, and the fetal tissue will be absent. Okay, so basically complete mole can transform into the invasive mole. Then gestational choriocarcinoma, it is also a malignant condition. It is diffusely anaplastic necrotic with a vascular invasion. So the trophoblast will be diffusely anaplastic necrotic with the vascular invasion. The villi are absent and the fetal embryonic tissue is present or may be absent, depending on the causative factor for the choriocarcinoma. Either it is gestational, it is coming from the gestational pathway, or it is coming from the sporadic or spontaneous spontaneous germ cell tumor. Okay, so that will be the differentiating point. Moving forward, now we have like pregnancy complications. So pregnancy is a very huge physiologic stress on the body of a woman. So the physiologic changes of the pregnancy are also like very stressful events, but if there is some complication, or if the pathology ensues, so we'll see them right now. So firstly we'll talk about abruptio placenta. Abruptio placenta, premature separation, partial or complete of the placenta from the uterine wall before the delivery. We know that give me a second. So we know that firstly, whenever the normal delivery is taking place, first the baby is delivered, and a few minutes or a few hours after that, the placenta is delivered. So placenta is basically separated from the endometrial wall after the delivery of the baby. So normally it must be adherent to the wall of it must be adherent to the endometrium throughout the course of the gestation. But if there is some premature separation of the placenta, so that is called as abruptio placenta. That can either be partial or complete. Okay, so presents in the third trimester, abrupt onset of the painful vaginal bleeding. Pathophysiology is blood loss from the maternal vessels, rupture from the maternal vessel in the decidua basalis. Okay, blood separates that decidua from the uterus. Now we have placental abruption. Firstly, there will be a risk factors. So maternal hypertension or preeclampsia, abdominal trauma, prior placental abruption, or cocaine or tobacco use. So all of these factors are leading to the placental abruption. Then the clinical manifestations may include sudden onset vaginal bleeding in 80% of the cases, abnormal abdominal or back pain, high frequency or low intensity contractions, and hypertonic tender uterus can also be seen in the placental abruption. Diagnosis is basically dependent on the primary. So diagnosis is made primarily by the clinical presentation. Ultrasound not required for the diagnosis to rule out placenta previa. Ultrasound, it is not required for the diagnosis. We do the ultrasound to rule out the placenta previa because that can also bleed. Okay. Then we may show retroperitoneal hematoma. Okay, on the ultrasound, the abruptio placenta, that can also show retroperitoneal hematoma because of some reasons. Complications. This may lead to because there is bleeding, so the bleeding may lead to maternal shock, fetal distress, or even demise can be there. Disseminated intravascular coagulation. So basically, whenever there is delivery, there are a lot of chances of development of the disseminated intravascular coagulation, because firstly, the pregnancy physiologically is a prothrombotic state. Pregnancy favors the thrombosis. Secondly, if there is amniotic embolism, in that case, the tissue factors are stimulated that result in the development of disseminated intravascular coagulation. And thirdly, here we are talking about it that during as a complication to the abruptio placenta, the female can develop disseminated intravascular coagulation. Ischemic cortical necrosis, that is a rare cause of acute renal failure. So cortical means the cortex of the kidneys. So rare cause of the acute renal failure related to the ischemia and disseminated intravascular coagulation can lead to the permanent renal failure. Clinical presentation lead to acute renal failure, anuria, hematuria, maybe growth or flank pain. So basically the catch here is that whenever there is extreme shock or whenever there is a lot of bleeding going on from the abruptio placenta, resultantly the kidneys will be perfused less than the normal values. And if the perfusion of the kidney decreases, or maybe there is disseminated intravascular coagulation, resultantly there is a thrombosis of the renal artery, and if the thrombosis of the renal artery is present, resultantly there is hypoperfusion of the kidney. So all of these situations which are leading to the hypoperfusion of the kidneys, that can cause the cortical atrophy of the kidneys, and the cortical atrophy of the kidneys can then present with acute renal failure or anuria, hematuria, and growth of flank pain. Let me see what anuria is. Anuria. So anuria means failure of the kidneys to produce the urine. So there is no urine at all. Moving forward, we are talking about the disseminated intravascular coagulation in the obstetrics. So how does that take place? Disseminated intravascular coagulation, firstly there will be placental damage. Okay, after placental damage, there will be release of tissue factors from the placenta into the maternal circulation. That will lead to activation of the intravascular coagulation. circulating microthrombi will be formed. Now, depending on the origin or maybe the site of the microthrombi, there will be organ ischemia, and on top of that there will be fibrinolysis of those clots that can lead to increased D dimer, and increased level of D dimer is the diagnostic point. Then, since there are a lot of unnecessary thrombi formation, that leads to the platelet consumption, and there will be thrombocytopenia, and coagulation factor consumption that leads to increased level of PT and APTT. PT for the extrinsic pathway, and APTT is basically the diagnostic point for the depletion of the factors of the intrinsic pathway, and all of that leads to bleeding. So there will be simultaneous bleeding and thrombosis in the case of disseminated intravascular coagulation. We have discussed that in the hematology and oncology sections. So here you can see there is hemorrhage, but that is concealed bleeding because bleeding is not evident. In the case of abruptio placenta, both of these are abruptio placenta. The visible vaginal bleeding is caused if the blood comes all the way here out of the vagina. If it is forming a hematoma or localized hematoma, then that will be a concealed bleeding. Even that is not a good thing, because if there is a concealed hematoma development, so the nutrition of the child can be affected drastically, nutrition and the oxygen supply to the fetus. And if there is visible bleeding, so that is a basically diagnostic point that now you know that there is bleeding ongoing, so you can do something about that. Morbidly adherent placenta. So firstly, we are talking about morbidly non-adherent placenta. It's not called that. I'm just talking about the placenta abruptio or abruptio placenta. Now we are talking about the placenta that sticks to the endometrium and does not want to leave. So morbidly adherent placenta. Normal placenta attaches to the decidua. Abnormal decidua leads to abnormal attachment, and placenta attaches directly to the myometrium. So now if we talk about the layers of the end of the uterus, so there is serosa on the outside. Inside the serosa we have the myometrial layer. Okay, so this particular thing is the myometrial layer, and then we have different layers of the decidua. So decidua basalis is the layer, decidua basalis, right? Decidua basalis is the layer to which the placenta normally attaches. Then we have the decidua. Let me see the layers of the endometrium. No, it's not endometrium. The uterine layers. Uterine, layers. So here we have it. I guess we are looking for the picture. Endometrial layers. So the endometrial layers are functional layer, basal layer, and myometrium. So residua functionalis, and then we have the residua basalis, and then there is myometrium. So functional layer and the residua basalis. So placenta inserts into basalis layer, I guess. Placenta inserts into residua basalis. So placenta, residua basalis uterus. So the maternal portion develops on the it's coming to the placenta membrane separation. Okay. So basically the thing is, I was a bit wrong. So this is serosa, then we have myometrium, then there is endometrium. So the outer layer of the endometrium that sheds off during the menstruation is called as the residua functionalis, while the layer under the functionalis is called as the residua basalis, and the placenta. So basically the residua basalis is making the maternal component of the placenta. You may call it like that. So now we will call about different condition. Normally this is placenta. Okay, let me make it of a different color. So suppose we make it like that. So normally this is the extent of placenta, right? If the placenta is inserting into the myometrium or involving myometrium due to some reason, maybe that decidua is not functional or decidua is not formed properly, there is some anatomic defect in that, resultantly the placenta is going to insert itself into the myometrium, and that is a very dangerous condition. Now we'll see those conditions. So starting off with this one. So there is abnormal decidua that leads to the abnormal attachment, and placenta attaches directly to the myometrium. Risk factors are prior C-section, most important risk factor, or uterine surgery involving the myometrium. This will leave a scar tissue which will inhibit the normal decidualization later on. So if there is prior C-section, that is the most important risk factor, or uterine surgery involving the myometrium. So in that case the myometrium is scarred, and if there is a scarring of the myometrium, that will lead that will inhibit or that will interfere with the further decidualization later on. Okay, so suppose that we cut this is the uterus, and we cut the uterus from outside like this. So in that case, we just invaded these all of these layers, like we cut the myometrium and then we cut the decidua overlying that. So when the scar will be forming the myometrium, maybe the decidua layer of the endometrium does not form over that. So that is impaired decidualization. Then inflammation, placenta previa, and advanced maternal age and multiparity, these are also risk factors, but the most important risk factor for the morbidly adherent placenta is the prior C-section. Then we have inflammation, placenta previa, advanced maternal age, and multiparity. There are three types distinguishable by the depth of the penetration. So first one is the placenta accreta. Now let me remove this one. It's gonna take time, so let's do it like that. Okay, so this does not bother me much, but let's do that. Now we have placenta accreta. The placenta attaches to the myometrium without penetrating it, and it is the most common type. Placenta accreta, it attaches to the myometrium without penetrating it. Like the placenta, suppose this is myometrium, and overlying is the decidua, like this one. So the placenta has come all the way to the decidual inner layer of the decidua, and it is touching with the myometrium, but it is not penetrating that. That is called as placenta accreta. Then we have placenta increta. So placenta penetrates into the myometrium, that is called, like it is, and in this case like this is myometrium, and outside that we have the decidua, and the placenta has come all the way into the myometrium, that is called as placenta increta. Then we have placenta percreta. So placenta penetrates or perforates through the myometrium into the uterine serosa all the way out. So invades the entire uterine wall and can result in the placental attachment to the rectum or bladder and can result in hematuria. So what is happening here now, let's suppose this is the myometrium, outside that we have decidua, and here we have serosa. So the placenta comes into the decidua, into the myometrium, and then goes all the way to the serosa and may come out of that as well, and may attach on the urinary bladder that is present anterior to the uterus. So it is a very dangerous condition that is called as placenta percreta. So accreta means that it is just in close proximity, or that it is just abutting the myometrium. It has not entered that. It is outside myometrium. In the case of increta, it is into the myometrium, and in the case of percreta, it has penetrated or perforated the myometrium all the way to the serosa, maybe even further. So presentation of the morbidly adherent placenta, how does the patient present to us? Often detected on the ultrasound prior to the delivery. Okay. Then we have no separation of the placenta after delivery. Postpartum bleeding can cause Sheehan syndrome. So if there is postpartum bleeding because of there is morbidly adherent placenta, and we try to pull it out, and because it was morbidly adherent, there was some tearing of the arteries inside the placenta, or maybe into the endometrium or myometrium. So resultantly there is a lot of blood loss, and that a lot of blood loss can lead to Sheehan syndrome. Now what is Sheehan syndrome? Sheehan syndrome means that this is the pituitary. If there is excessive blood loss during the pregnancy, the blood supply to the pituitary is lost, and if there is lost blood supply to the pituitary, resultantly there can be serious necrosis or ischemia ongoing in the pituitary, and that ischemia will lead to a generalized there will be decreased hormone production from this one, like there will be decreased hormone production from the pituitary, and that is the presentation of the Sheehan syndrome. We will study the Sheehan syndrome in the next unit, that is endo unit. So let's continue. Sheehan syndrome is basically a disorder of the pituitary hypofunctionality. So postpartum bleeding can cause Sheehan syndrome. Now here you can see the placenta accreta. So we are talking about accreta, which means that the placenta is just adherent to the myometrium. So here you can see this is the placenta, and here we have the endometrium, the pale layer, the whitish layer, and then inside that we have myometrium, like this is the muscular layer, that is myometrium, and outside that we have serosa. So the placenta has just come close, or just attached to the myometrium. It has not entered the myometrium. So normal decidua looks like that, and then we have the accreta. Here we can see different pictures. Normal placenta and stratum bizalis. Okay, stratum bizalis means the decidua bizalis, I guess it is also called decidua bizalis. So in the case of placenta accreta, suppose that this pale pink color, like the outside one, like this one, I'm removing this one. So that pale pink thing is the myometrium. In the case of accreta, you can see it is coming in close proximity to that. In case of placenta increta, it has penetrated or entered this one, like the myometrium. But for the percreta, it has gone beyond that, and it is also perforating the serosa coming out of that. What is placenta previa? Previa means going before, and placenta before baby. So if the placenta comes before baby, that is called placenta previa. Now again I would like to highlight that normal deliveries have the pattern or sequence that the baby will be delivered first, and a few minutes or hours later the placenta will be delivered. If the placenta comes first, or the situation is basically that suppose this is the uterus and here we have the cervical. So on the internal cervical os we have implantation of the placenta over here, and the fetus is lying behind that, like that. So whenever the fetal head tries to pass into through the cervical os, there can be frank bleeding and mother can go into shock. So let's read that. Attachment of the placenta to the lower uterine segment, for example, over or 2 cm from the internal cervical os. It can either be on the cervical os or 2 cm from the internal cervical os. Even suppose that it is not attached on the cervical os, even it is attached like over here maybe, or maybe somewhere over here. So when the fetus tries to pass through this canal, they will be bleeding. Yes, a preview of the placenta is visible through the cervix. Normally we cannot see the placenta through the cervix, but we can in that case. That is called placenta previa. Risk factors: prior placenta previa, prior cesarean section or other uterine surgery, multiparity, advanced maternal age, or smoking. Clinical features include painless third trimester bleeding, and diagnosis or management is done by transabdominal followed by transvaginal sonography. So that is basically for the diagnosis, that you do the transabdominal and then the transvaginal sonography, and no intercourse or digital vaginal examination. If you do the transabdominal or transvaginal sonography and you saw placenta previa, so the intercourse and the digital vaginal examination is strictly contraindicated, because in both the situations there can be a damage to the placenta, and if there is a damage to the placenta, that can lead to hypovolemia in the mother because of bleeding, or also the fetal demise is expected in the case of bleeding or severe bleeding in the placenta previa, and these mothers are always supposed to have a cesarean section. Normal delivery is contraindicated in these conditions. So here you can see the placenta previa. It is partial placenta previa. This one is partial placenta previa, in which the placenta is basically 2 cm from the cervical os, or you can say that it is close to the cervical orifice. And here you can see it is complete placenta previa, where it is obstructing the cervical orifice. What is vasa previa? Previa before, and the blood vessel come before the baby. So now let's see the picture of that firstly. So here you can see that the umbilical cord or the blood vessels, they are present on the cervical os, and these are called as the vasa previa. The previa before and the blood vessel come before the baby. Fetal vessels run over or in close proximity to the cervical orifice or cervical ostium, may result in the vessel rupture, exsanguination, and fetal death. Exsanguination means bleeding. Okay, so they always use these fancy terms. Exsanguination. Exsanguination means the action of draining person, animal, or organ of blood. So exsanguination means that the fetus will be deprived of the blood because the fetal blood is present in the fetal circulation. If the fetal blood vessels are ruptured, so there will be exsanguination of the blood from the fetal body, and there will be fetal demise. Then it presents with the membrane rupture, painless vaginal bleeding, fetal bradycardia like less than 110 beats per minute. Emergency C-section must be done. Frequently associated with the villamentuous umbilical cord insertion. Normal umbilical cord inserts into center of the placenta. Okay, but the villamentuous cord inserts in the chorioamniotic membrane rather than the placenta. Fetal vessels travel into the placenta unprotected by the Wharton jelly, and there is a risk of rupture. So normal umbilical cord inserts into the central placenta. Okay, in the case of a villamentuous cord, the cord inserts in the chorioembryonic membrane. As you can see over here, it is inserting in the chorioembryonic membrane, but you will see that in the Google as well. So fetal vessels travel to the placenta unprotected by the Wharton jelly, and there is a risk of rupture. So what is that? Villamentuous cord. Villamentuous cord. So villamentuous cord is basically villamentuous cord insertion is a pregnancy complication that happens when the umbilical cord from a fetus does not insert into the placenta correctly. So here you can see, I guess this is a good picture. So normal umbilical cord insertion is like going all the way directly into the placenta. If there is villamentuous cord insertion, so that is basically adherent or attached to the umbilical cord is attached to the chorioamniotic membrane, and from there the blood vessels are going to the placenta. and those are the exposed blood vessels because there is Wharton jelly inside the umbilical cord that protects the blood vessel from any shear stress. But if it is present in the chorioamniotic membrane, so the Wharton jelly is not present over there, so resultantly those blood vessels are exposed to the tethering forces or tractional forces. And here we have the Velamenchis cord insertion with veda previa. So there is double condition, like there is Velamenchis cord insertion, on top of that there is veda previa. So I don't have a pointer right now, so you can see that the blood vessels, the exposed blood vessels, are present under the head of the fetus. So either during the delivery or even before the delivery, there can be some hemorrhage in those blood vessels, there can be damage to these blood vessels, and if there is a damage, there can be exsanguination or the fetal death. So this is the concept of Velamenchis cord insertion. Moving forward, we have it like you can see this is the placenta here, and umbilical cord is over here, and there is placenta subcenturiate lobe. I don't know what that is, and Velamenchis attachment over there. Subcenturiate lobe of the placenta. I guess this is some structure. Subcenturiate lobe of placenta. Subcenturiate lobe of placenta is a condition in which one or more accessory lobes develop in the membrane apart from the main placental body, to which the vessels of the fetal origin usually connect them. Okay, and that is a condition which we find in the veda previa and the Velamenchis cord insertion. Then postpartum hemorrhage. It is due to 4 T's. Why will there be postpartum hemorrhage? Tone, uterine atony. Okay, so there will be tone, uterine atony most common than trauma, lacerations, incisions and uterine rupture, thrombin, coagulopathy, and tissue retained products of the conception. So that is basically the 4 T's which can result in a postpartum hemorrhage. Tone, uterine atony. The uterus is basically when the placenta, suppose that this was a uterus and the uterus was, the placenta was right over here. Now the placenta is moving out, like the placenta is to be removed. So the placenta, if it comes over here and it is basically delivered outside, it is delivered out of the body. Pardon me. So it is delivered out of the body, and we have like it's gone. So the endometrium that was left behind, that was kind of lacerated, but the muscles of the uterus, they contract together to close those leaking or oozing blood vessels, and resultantly what do we get? We get the tone of the uterus protects from excessive bleeding. So if there is postpartum hemorrhage, so it means that the uterus has become atonic and the tone of the uterus is not assisting in controlling the blood. Then there can be trauma, lacerations or incisions, uterine rupture, thrombin that leads to coagulopathy, and tissue retained products of conception can also be seen. Then we have ectopic pregnancy. What does that mean? In the case of ectopic pregnancy, implantation of fertilized ovum in a site other than uterus, most often in the ampulla of the fallopian, most often in the ampulla of the fallopian tube. So we talked about that before this as well. So suppose this is ovary, and here we have the fallopian tube moving upward and like that. So it does not go like this, but suppose this is like that. So this is the fallopian tube. Here we have the ampulla, and then we have the narrow point, that is isthmus, and then interstitium. So this looks something like that. So the ampulla is the most common site of fertilization. The ampulla is the site of fertilization. So the most common site of ectopic pregnancy is also the ampulla of the fallopian tube, mid portion of the fallopian tube. Presentation: suspect with a history of amenorrhea and sudden lower abdominal pain. So the patient will tell you that her last menstrual period was like 3 months ago, and now she is also having lower abdominal pain. Pain may be associated with or without bleeding. Lower than expected rise in HCG based on the rates. Confirmed with ultrasound and often clinically mistaken with appendicitis, because the fallopian tube, because uterus is present in the pelvic area, and if suppose that this is the right fallopian tube in which there is ectopic pregnancy, so you may suspect that there is appendicitis going on. But when you will find the history of amenorrhea and all that, abdominal pain, and there is some bleeding from the coming out of the uterus as well, so now that is going to take you to the ectopic pregnancy. What are the risk factors? Prior ectopic pregnancy. So the prior condition is also a risk factor for the condition to develop later on. So we saw previously about I guess about the vesa previa. Now it was about the placenta accreta, placenta previa. Yep. So the placenta previa, we saw it here that the risk factors include prior placental previa. So now we are talking about this one, like ectopic pregnancy. So what is the risk factor? Prior ectopic pregnancy. Then there may be history of infertility, self-meningitis, pelvic inflammatory disease is a big one. That if there is some infection with the gonorrhea or chlamydia and there is a history of that, so even if they don't tell you that there was pelvic inflammatory disease, you must suspect that there might be pelvic inflammatory disease, and you must make your diagnosis according to that. There can be a ruptured appendix as a risk factor, because whenever there is a ruptured appendix, there will be inflammation in the whole, the peritoneal area and stuff like that. So basically there will be inflammation, and that inflammation may lead to pelvic inflammatory disease as well, and salpingitis can be there. So that salpingitis is a risk factor for the development of ectopic pregnancy later on in the life. Then prior tubal surgery, for example, the person who is having tubal ligation for the contraception, or maybe some other causes, smoking and advanced maternal age. Treatment is done with a surgery or methotrexate. Methotrexate can be used for the treatment. Methotrexate was also used in the treatment of hydatidiform mole. Okay. Then spontaneous abortion or miscarriage. What is meant by the miscarriage? So pregnancy loss before 20 weeks is called as miscarriage. What is miscarriage? Spontaneous abortion or miscarriage is defined as the spontaneous loss of pregnancy before 20 weeks. After 20 weeks, it is called as stillbirth or fetal demise, because before 20 weeks, the fetus is not alive. So, spontaneous abortion before 20 weeks is referred to as miscarriage or spontaneous abortion. If it is happening after 20 weeks, it is called as fetal demise or stillbirth. Present as vaginal bleeding, often requires D and C to remove all the tissue. It is dilation and curettage. So, dilation and curettage can be required for the complete removal of all the tissues. 50% of the cases are due to the fetal chromosomal abnormalities. Risk factors include maternal smoking, alcohol, cocaine, maternal infection like for example torch infection, hypercoagulable states, and lupus antiphospholipid syndromes. Then we have septic abortion. What does that mean? Risk factors are pregnancy termination with the retained product of conception. Okay. So microbiology is septic abortion. Okay. What is septic abortion? Septic abortion means refers to any abortion, spontaneous or induced, that is complicated by the uterine infection, including the endometritis. Septic abortion typically refers to the pregnancies of less than 20 week gestation, while those more than 20 weeks of gestation with intrauterine infection are described as having intra-amniotic infection. So here we are talking about the septic abortion, which means that there was some abortion and that was followed by the there is like inflammation or something like that. So pregnancy termination with the retained product of conception. So either we did not do dilation and curettage at all, or there was some dilation and curettage that was done, but that was not enough. So resultantly, the gram-negative bacilli and the staphylococcus aureus can grow over there. Clinical picture will be fever, chills, lower abdominal pain, bloody or purulent vaginal discharge, boggy and tender uterus with the related cervix. Pelvic ultrasound include retained product of conception, increased vascularity, echogenic material in the cavity, and thick endometrial stripe. Amniotic fluid abnormalities. They can be like polyhydramnios, too much amniotic fluid. Causes and risk factors include often they are idiopathic. Fetal swallowing malformations will be there. Esophageal duodenal atresia and anencephaly will be seen. Okay, for the polyhydramnios, what are the risk factors? Fetal swallowing malformation. Suppose the stomodium or the mouth of the fetus is not developed properly, or maybe the fetus is having anencephaly, and due to that the swallowing centers are not developed. So stuff like that. So basically the thing is that the amniotic fluid is the major chunk of the amniotic fluid is coming from the fetal urine, and that fetal urine is then swallowed by the fetus itself, so that the amount of the amniotic fluid could be retained in a equilibrium in the optimum quantities. It does not if it increases the suboptimal level, if it increases the optimal level, it is called as polyhydramnios. If it becomes suboptimal or decrease or lower than the optimal level, that is called as the oligohydramnios. Pardon me for the stammering. I have not taken a good sleep for a very long time now. So we were talking about the polyhydramnios. So fetal swallowing malformations can lead to this thing. For example, the esophageal or duodenal atresia and anencephaly. In the case of maternal diabetes, there will be fetal hyperglycemia, and the fetal hyperglycemia, whenever there is hyperglycemia, that leads to polyuria, because glucose is an osmotically active agent. If there is excessive amount of glucose in the urine, that extracts the water with that, so that leads to polyuria. Fetal anemia, it leads to high fetal cardiac output, okay, and increased urine production will be seen. Can occur with the parvovirus infection. So fetal anemia can be seen with the parvovirus infection, because if there is anemia, because of that the parvovirus dwells in the reticulocyte or the premature RBCs. RBC precursors, yeah. RBC precursors are basically infected by the parvovirus. So if there is intrauterine parvovirus infection, so there will be anemia, and whenever there is anemia, resultantly there is going to be high fetal cardiac output, and that high cardiac output will lead to the increased urine production and can occur in parvovirus infection. Multiple gestation, for example, more fetal urine is being produced, and that is going to lead to more hydamnios, no, more amniotic fluid, so that leads to polyhydramnios. So here is the chart. Fetal gestational obstruction, esophageal, duodenal, or intestinal atresia or anencephaly that leads to impaired fetal swallowing, that leads to polyhydramnios. Or maybe there is high fetal cardiac output, alloimmunization, parvovirus infection, or feto-maternal hemorrhage that increase the fetal urination, and that leads to polyhydramnios. So either there is decrease in the swallowing or there is an increase in the urination. Both of these conditions can lead to polyhydramnios. Let me see what is alloimmunization. Alloimmunization. So alloimmunization means an immune response to the foreign antigen after exposure to the genetically different cellular tissues. Although alloimmunization is a natural event during pregnancy, frequently it is undesirable outcome of the blood transfusion of blah. Alloimmunization is the immune response to non-self antigens. So whenever there is alloimmunization, like suppose, because fetus is a okay, let me not confuse you. So look at alloimmunization. Maybe it comes later on in the immunology section somewhere else, but alloimmunization is basically an immune response to the allogenic antigens or the foreign antigens. Moving forward, we have oligohydramnios. Oligohydramnios means there is too little amniotic fluid. So what happens in that condition? Causes are fetal renal abnormalities. For example, there is bilateral renal agenesis, or maybe there is posterior urethral valves in the males. Why do they develop? Because of the prevalence of the Wolffian duct. And what is Wolffian duct? The Wolffian duct is the mesonephric duct. Yep, mesonephric duct is also called as the Wolffian duct, while the paramesonephric duct is also called as the Mullerian duct. So remember these things. Placental insufficiency, preeclampsia, maternal vascular diseases. So placental insufficiency, for example, in the case of preeclampsia or the maternal insufficiency, maternal vascular diseases, they may also lead to oligohydramnios. And then we have premature rupture of the membranes, for example, in the case of abruptio placenta. Any profound oligohydramnios can cause Porter sequence. So what is Porter sequence? Porter sequence means that the fetus is basically wrapped in the amniotic cavity, amniotic membrane. So this is fetus. Suppose this is a very asymmetric fetus. So suppose this is fetus, and the amniotic cavity looks something like that. The blue one being the amniotic membrane. So if there is oligohydramnios, the amniotic fluid is present over here. So if there is oligohydramnios, resultantly the amniotic membrane will wrap completely around the fetus. So the fetus will not have a room to grow. Resultantly there will be flat facies, clubbed foot, the chest will not be able to expand. That will result in the pulmonary hypoplasia. Along with that, since there is oligohydramnios and there is a very low level of amniotic fluid, so that amniotic fluid that was supposed to enter the lung and cause the pulmonary circulation of the amniotic fluid, that will not be there. So resultantly there will be pulmonary hypoplasia, and the whole sequence is called as Porter sequence. When do we call any congenital abnormality or intrauterine abnormality a sequence? So a sequence is a condition in which all the constellation of symptoms which we can see are associated to a single cause. For example, in this case the single cause is oligohydramnios. So that particular condition is called as sequence. Another sequence is Pierre-Robin sequence. So in that case there is micrognathia. That is the first, I guess, the primary cause is micrognathia. Micrognathia causes the tongue to be present, tongue to be fallen back, or maybe tongue goes upwards, and that hinders the palatal formation, so that leads to cleft palate and all that. So remember this thing. Then we have hypertension in pregnancy. So what are the causative factors of hypertension in the pregnancy? They can either be chronic hypertension. So the mother was otherwise hypertensive, like it was not due to pregnancy, she was already hypertensive. So systolic blood pressure of more than 140 millimeters of mercury, or diastolic blood pressure of more than 90 millimeters of mercury prior to the conception or 20 weeks of gestation. So prior to conception or 20 weeks of gestation, prior to 20 weeks of gestation, if she is having this condition, it is called as chronic hypertension. Then gestational hypertension, new onset elevated blood pressure at more than 120 weeks of gestation, no proteinuria or end organ damage will be seen. In the case of preeclampsia, new onset elevated blood pressure at more than 20 weeks of gestation and proteinuria or signs of end organ damage can also be seen. So new onset elevated blood pressure at more than or equal to 20 weeks of gestation, proteinuria or signs of end organ damage can also be seen. In the case of eclampsia, there can either be preeclampsia or new onset grand mal seizures can also be seen. Moving forward, we have gestational hypertension. What does that mean? Blood pressure of more than 140 by 90 millimeters of mercury after the 20 week of gestation. If she is having this hypertension before 20 week of gestation, so the hypertension is not because of pregnancy. It is like chronic hypertension that is going on before pregnancy due to some other reasons. either essential or secondary. So the gestational hypertension, any hypertension is referred to be as gestational hypertension if the BP is more than 140/90 after the 20 week of gestation. No pre-existing hypertension, no proteinuria or end organ damage will be seen. So we will see about proteinuria and end organ damage in preeclampsia and eclampsia. So in the gestational hypertension, the only thing is there is an elevated blood pressure. Treatment is antihypertensive hydralazine, alpha-methyl-dopa, labetalol and nifedipine, delivered at 37 to 39 weeks. Hypertensive moms love nifedipine. So these are the drugs that can be given. These are non-teratogenic drugs, and they are given for the hypertension in the pregnant women. These includes hydralazine, alpha-methyl-dopa, labetalol and nifedipine. So the mnemonic is hypertensive moms love nifedipine. Then we have the pathogenesis of preeclampsia, which we'll discuss in the next session. Until then, Allah Hafiz, Himayallah.